Good morning. I gather that we've now gone live. I'm Owen White. I'm speaking to you from Australia. For those of you that don't know where Australia is, it's that large country to the south that stops the rest of the world from spinning off its axis. We're here today to talk about visual snow, and I've been given a few issues that probably need to be discussed, but I think it's important to explain who I am, what I do, and why I do it. Okay, I'm a neurologist. I've been working for more years than some of you have been alive. I particularly work in neuro-ophthalmology, and my area of specific interest has been how the brain controls eye movements and why those eye movements occur. This might sound a little bit far away from visual snow itself, which is clearly for most people a visual perceptual issue. In fact, the reason we move the eyes is so that we can see, and the two are inextricably linked. So I've been working in that area for quite some time, and indeed I've been working through all the era of the awareness of visual snow. This was first identified as an entity as such in 1995. But prior to that time, people like myself saw patients who complained of persistent visual disturbances in conjunction with a range of other symptoms. It was always difficult to know what to do with those patients. From my own perspective, initially I considered that it might be a migraine variant, and it was often called persistent migraine visual disturbances, but yet rarely, if ever, responded to migraine therapy. So as such, I did form the opinion that these patients were not crazy, which was not a general opinion at the time. But there was always a group of neurologists in particular that felt that this was truly a neurological disorder, but difficult to determine and difficult to determine its frequency. That was not entirely true in ophthalmology, because within the knowledge set of ophthalmologists, there was no real explanation for this. Now, that means that we've come to a situation where we accept that visual snow is actually a syndrome. That doesn't necessarily mean it's a disease. It means it's a collection of symptoms that go together with greater than chance risk. From the medical perspective, it's taken a long time for people to come to terms with this, because doctors as such have been raised in a milieu where we interpret what we see. So for several hundred years, at least since 1870, when the neurological examination was first devised, we've actually concentrated on movement, because you can see people fall over. You can see the fact that they can't use their arms. You can see the fact that they're clumsy. It's very hard to see either a sensory perception or indeed people's feelings, or indeed people's feelings about their disordered sensory perception. It is much easier to write this off as being essentially an emotional response to something that most people in the community would not worry about. In part, that can be true in some people, but this has got a thread of consistency that should have triggered people to consider it as a problem much earlier than it has. Now, most doctors just don't have the capacity to integrate that phenomenon. I'm not putting myself on a pedestal or not. I've done that often enough in the past. The reality is we're not trained that way, and doctors are trained to work within a framework of solid facts. Those facts are only now emerging, given that we have some potential research facilities that can assess this. So the take-home point from this is that, firstly, visual snow syndrome as such is a real entity. The subtext to that is that what we're defining as visual snow syndrome is actually part of a range of disorders, and it has been defined as visual snow syndrome with the characteristics that you've all been made aware of, on the basis that we need to have some consistency for the purposes of investigation. The people that have visual snow syndrome are not intrinsically depressed, anxious, confused, disorientated, mad, or anything else. Having said that, the constant awareness of sensory disruption in conjunction with either a lack of belief on behalf of those you live with or those to whom you go for help can certainly engender substantial anxiety and depression. Now, if we go back to how doctors might pursue it, the interpretation of this has always been emotional. And the reason for that is because they don't have the mechanisms for interpreting in any other way, in the same way that more primitive societies might look at a telephone or a fax or the internet and have no capacity to integrate that into their knowledge base and therefore consider the outcome of it as magic. We consider the outcome of visual snow to be primarily psychological, or have done so for a long time. Now, in recent years, Peter Goadsby in England, and in fact a number of other countries as well, over those years, has worked very hard to define the syndrome and has made enormous inroads into getting this accepted as an entity. And the fact that it is an entity has actually generated some interest, purely and simply because people have suddenly realized that this is an opportunity to start to understand sensory processing and sensory integration. That might not sound important to many of the people who are suffering from the syndrome, but the impact of studying these things over the next few years could be massive as looking at people who have strokes and trying to work out the cause of stroke. There are just as many people suffering from sensory disturbance as there are people suffering from motor disturbance. It is an ignored area. In order to give you a little bit of background about how the brain works, it is not localization related as we always think. We do have a motor area, we do have a visual area, but they work on the basis of their interconnections with other parts of the brain. So the brain works on the basis of interconnecting networks, much like a public transport system works. And the way of measuring it is by looking at input and output. Now, much like a public transport system that works all day, there's intrinsic activity in the brain going on all the time. But then you increase the load at different times depending on the stimulus, whether that comes from inside the body, hunger, sadness, fear, or whether it actually is an external stimulus that's produced a response. Most of those responses are learned very early on in life and reproduced that way. Now, in terms of vision, let's go through what vision is. I want you all to do one thing. I want you to close your eyes for a second or so, and I want you to keep them closed until I tell you to open them. And what you will notice when you open them is that there's a small period of almost no vision, and then there is vision. Okay, I want you to open your eyes now. Okay, so most of you have noticed precisely what I've told you. The reason for this is that vision isn't real time as we think it is. In fact, you have about 130 to 140 million receptors in each eye and about 140 million cells at the back of the brain, which start the process of seeing. You've only got 1.1 million nerve fibers traveling from each eye to the back of the brain. So you cannot transfer all of that visual information immediately. And what we actually see is a perception that we've built up over a little bit of time, milliseconds, and then we update that all the time in much the same way that we update or back up our computers. We really only update what's changed. So vision is not real time. It's not a television camera. It's a perception that the brain has to maintain. Now, another fact is that the visual cortex, indeed all cortex, we think of it as having a single function. It does have a single function. It sees. However, it does not have only one input. You do have primarily visual input to visual cortex, but you also have hearing, balance, touch, etc., all projecting there, all of which have to be filtered out in order to maintain a pure visual environment. That doesn't always happen. And if it doesn't happen, what you end up with are things like visual snow, little flashes of light, floaty spots, etc. So this could be failed inhibition. Now, we've done some work in this area, and we're doing some work before the definition of visual snow came out, because we were trying to look at whether the inhibitory system was in fact generalized in sensory systems and motor systems, or in fact whether there were separate inhibitory systems or filtering systems, if you want. We've been working on that for quite some time and have had certainly some success in demonstrating abnormalities in visual snow, but these need to be defined so that in the long run we have some way of measuring a physiological abnormality against which we can also measure the results of therapy. That's my background, and I'm certainly going to be prepared to answer a few questions, and a few have been put through to me already. So I'll try and address those specifically. The first one was, what are the current mechanisms of visual snow? Well, there are a number of groups working in this area, and not many, just a few. There's Peter Gosby's group in England who are looking at functional imaging and trying to localize where some of the deficits might be. My own feeling is that if you're talking about a network, the abnormality could be localization related, or in fact it may be anywhere in the network, or it may be diffuse and related to transmitter systems. We don't know. The outcome may be the same no matter what the underlying pathology is. There has been some considerable interest in the possibility that there are abnormalities in the circuit that goes from the thalamus, which is deep within the brain and is a part of the brain that receives most sensations and then distributes it to the brain, the rest of the brain. Those so-called thalamocortical circuits may well be involved, and the people in Sydney have been working on this to some degree, looking at the influence of colour in particular. There's the possibility that we are dealing with a transmitter system abnormality that might affect either a particular circuit or a particular part of the brain. Very difficult to prove or disprove, but the work is going ahead in that area with what's called magnetic resonance spectroscopy, which basically lets you look at individual chemical signatures in different parts of the brain. Also looking at functional imaging to see whether we can localize it and then decide whether or not there may be a specific transmitter system there. And then there's the more general theory that we've been pursuing, that this is actually a failure of an inhibitory network which is diffused throughout the brain. The question arises as to whether this is behavioral, in that people have just not learned how to suppress, or whether it's in fact due to a structural abnormality. I think the answer in the long run will be both. Now, the next question that was put to me, is there a possibility that idiopathic intracranial hypertension could cause visual snow? The answer is that anything could cause visual snow, but idiopathic intracranial hypertension as such is not generally associated with visual snow syndrome. And I see probably between 1 and 2 new cases per week of idiopathic intracranial hypertension. But certainly it might be the trigger in some patients. Somebody else has asked me to clarify a comment I made, which was when we were talking at the Visual Snow conference, was I said that you probably won't go blind from visual snow. That doesn't need to be taken out of context. What I should have said probably was, I have never seen anybody go blind from visual snow. I have seen people become quite distracted by their visual snow, but people don't go blind. Okay, so let's not overinterpret that. The next question was, why is anxiety connected to visual snow? The real question there should be, why aren't all people with visual snow anxious? Their life has been disrupted to the nth degree. Could anxiety also be an organic component of the visual snow syndrome? The answer to that is absolutely yes. Now, somebody has asked whether or not I feel that stem cells could play a role in treatment one day. I think it's important to understand that stem cells regenerate cells to some degree. They also have an anti-inflammatory effect to some degree. But we're talking about restoring function, which means that we would have to actually direct those cells to grow to a particular place and develop particular connections to not one, not 100, but thousands or hundreds of thousands of other cells. The possibility that we will have the technology to do that within my lifetime or several generations is so remote that I would say I don't think it's a realistic treatment for quite a long time to come. The next question was that Dr. Fulton said that the carboxylic THC may be a cause for visual snow. Now, there is the hallucinatory persistent perceptual visual disturbance that's been talked about for years. It's very likely that all sorts of hallucinatory drugs have the capacity to produce structural and functional abnormalities in susceptible people to some degree, and probably in all people as a dose-related phenomenon. That's not universal. It's maybe a reflection on our society, but it's uncommon in my practice not to see people who, it's uncommon in my practice to see people who have not had any contact with drugs. I find it very difficult to attribute visual snow to a previous contact with drugs that may have been many years in the past. Part of that question also was whether or not there was potential for visual snow to dissipate. I have seen occasional people undergo spontaneous resolution, pretty uncommon, but it has occurred. I've not seen it more than a couple of times over the past 30 plus years. The final question, well, not the final question, but the toughest question is, what will a cure probably be like, or what is my goal, our goal? Will it be pharmaceutical or behavioral? The answer is it will be whatever it will be. We are pursuing both avenues as potential treatments, and it is highly likely that both will have some role to play in management in some people. Remember, this is a syndrome. It may have more than one cause. Now, final question here was, is there any way to know when your visual snow will stop getting worse or if they will ever get better? The short answer to that is probably not, but if it's been stable for 4 to 6 months, it's probably not going to change very much. Somebody has commented that they've had visual snow all their lives and they've coped with it, but their girlfriend is starting to get symptoms. And how can you help her? How can they be helped to cope? It's explanation and it's reassurance that no, they're not crazy, no matter what people tell them. You explain to them that they are not going to lose vision, that this is how they perceive the world. We all perceive it differently, whether we consider ourselves to be normal or whether we consider ourselves to be abnormal. Now, the reality is that if you reassure her that overall this is irritating, frustrating, aggravating, constant, but not disabling, that is the best way to help her. Medications have not been shown to make a significant difference. With one possible exception, lamotrigine has been trialled and has worked in a small number of people over and above the possibility of a chance resolution of the symptoms. Do I recommend it? Not really. Visual snow glasses have also been recommended. So these are colored lenses at a particular frequency in the blue-yellow spectrum. Some people actually get a lot of relief from it. But again, it's not universal, and that may be a reflection on the fact that there's probably more than one etiology. Somebody has asked me whether or not I know anybody in the Boston area who works in this area. The short answer to that is no, I don't. But the Boston Children's Hospital is a very good hospital, and that's where they're attending. But also at the Mass Eye and Ear, they have a very large department of neuro-ophthalmology, and there may be somebody there. I guess at that point, I've been talking for more time than I had planned, and I would be happy to address specific questions if I can work out how they're being put through to me. Justin, who's hosting this, might be able to help me a little. Now, I certainly have a chat on the side with a lot of comments being made, and I'm going to go through those and see if there's anything that I can address that we haven't already talked. I should also add, by the way, that many people will have other symptoms that occur probably with greater than a chance association. And that certainly came out when we were in San Francisco for the conference. Many people talked about a sort of depersonalization that they sometimes feel. Some people here have talked about heavy floaters. All of these do occur in association, but we've restricted the syndrome in order to have a fairly pure group of people with whom to work. Now, forgive me while I'm just reading through them. Somebody here has made the comment that their symptoms became quite severe after taking antibiotics and that they fluctuated every single time. That may be for complex reasons not specifically related to the antibiotics, although it's not impossible that almost any drug we put into ourselves could be a contributing factor to aggravating the symptoms if it changes function in networks. There's an interesting question here is, do I think that other parts of the body are involved in visual snow syndrome, like the vagus nerve or the inner ear? Yes and no. Firstly, I think the vagus nerve has a very strong input to the brain in many respects, and there is some interesting work on stimulation of the vagus nerve in terms of promoting rehabilitation for stroke and a number of other things. The inner ear is really an extension of the brain. It just happens to be outside what we think of as the brain. So I don't think of those so much as being outside other parts of the body. What I have said, though, is that I think that visual snow is a sensory misperception syndrome. In other words, we misunderstand how we interpret sensation. If that's the case, then there are other symptoms that will obviously arise in almost any sensory system. Tinnitus is well recognized as part of the syndrome. I think that Claire Fraser published a paper at Claire's in Sydney a couple of years ago that indicated that there was a greater than chance association of dizziness. There is also a syndrome known as persistent perceptual postural dizziness. These are people who develop vertigo with no apparent cause and often occurs in crowded environments where there's a lot of sensory stimulation as well. They, with quite a lot of confidence for many years, were called crazy. It's not a big step to consider that that might actually be another form of disordered sensory perception. A number of patients, and I see a lot of young women who complain of this, of migratory pins and needles. And the reason young women come in for this is because they're so sensitized to the possibility that they might have multiple sclerosis. I think this polymodal sensory disturbance is all part of a a larger syndrome with specific subsets, one being visual snow, one being dizziness, one being the pins and needles that migrate all over the body. And symptoms will come and go. And it depends partly on what's happening in the environment, what's happening in your internal environment, and just what's happening in the brain itself. Question here is, does derealization disorder cause visual snow? Because I had that. The answer is that no, it doesn't. I think it's part of the syndrome. It's just not what we defined. One of the things that I really do need to bring up, as you can see, there's been a burgeoning interest in visual snow, but burgeoning is probably being a little bit optimistic. There needs to be a burgeoning interest in visual snow. The Visual Snow Initiative has been an extraordinary step forward, and I know that you all have been involved in looking at that website, and I think you should encourage other people to look at it. One of the things that I should say is that the research needs money, costs money. People like myself don't take a salary for it. You know, I'm old, I get my money from other sources, etc. But there are a lot of young people who work with me, and they need to be supported. The facilities for investigation need to be supported. Now, I know that there is the GoFundMe program, and I would strongly encourage you to support that, but also to get other people to support it, to get them interested in the fact that this is actually a completely new area in neurology and the understanding of disease that needs to be investigated in the same way that stroke and epilepsy also need to be investigated. So I would strongly support that. Now, going back to the questions, and I'll probably come back with a pitch at the end. Somebody has super small floaters in the center of their vision, visible in the dark, gone when they turn on the light. They're saying maybe visual snow creates artificial light that makes floaters visible in the dark. In fact, all cells have, all nerve cells anyway, and probably most cells have intrinsic phosphorescence, you know, so you all see that, you've all seen those photos of plankton that are luminous in water at night. All our cells are generating energy, and they're all generating some light. So when you close your eyes, anybody close their eyes, the world doesn't go black. It's like a lot of little stars and sprinkles, etc. So there is intrinsic light within the system. You're supposed to be able to filter it out to some degree. If you can't, then you've got a variant of visual snow. I did see the second part of the question about the detox from THC, whether or not visual snow could potentially dissipate. The answer is that in most of the patients that have drug-related visual snow, it does not dissipate. Where there's a direct relationship, you take the drug, you get the visual snow, you stop the drug, it goes away. Yes, that certainly happens. But in the vast majority of people who have the syndrome, no, it doesn't go away. It's once triggered, it's triggered. Whether that's due to structural or neurochemical abnormality, I don't know. There's a question here why the static gets worse the longer one stays in the dark. The answer is, I don't really know, but you could talk about the fact that you have fewer competing sensory stimuli to suppress other things. And essentially, the more information we have coming in, the more we suppress the background, okay? So for instance, if you've got pain and you stimulate yourself in a lot of other ways, that pain becomes less. In this case, we're removing other sensory stimuli, and it's likely that the sensory stimulation that we do have, which is intrinsically generated, becomes more obvious. Okay, I think I'm actually down towards the bottom, and I'm not 100% certain what to do from here. It's now about 8:30 my time in the morning, and I know that I've got meetings coming up. If there are no pressing questions, I will just remind you that the Visual Snow Initiative website provides an enormous amount of information and is an incredible resource for people who have this syndrome or know people who have this syndrome. The more support it gets, the better it's going to be as a support mechanism, and I would strongly encourage you to get there. I would also be strongly supportive of the GoFundMe CrowdRise, and for that you can go to https://www.crowdrise.com/visualsnowi, and that's coming up on the so I would strongly encourage you all to go for that. I think that at that stage, I think we covered that most things, and you know that there's a series of talks coming up, and I would suggest that you tune in for the next talk, which will be Joanne Fielding, who has been working for me and with me and against me for many, many years, but in fact, without her, this laboratory wouldn't run, and she knows as much, if not more, about the underlying mechanics and science of visual snow as anybody. Okay. Thank you very, very much for joining us. Remember, visual snow is real. Visual snow needs support. Visual snow needs you. Thank you very much.